Okay. Good morning, everyone. Hello, hi. Sorry, you're little, it's a small group, but also spread out. So I'm going to do my best to not turn my back on anybody. My name is Jen Hallman. I work for the Los Angeles County Department of Mental Health. I am a licensed clinical social worker, and I've had the pleasure, I've been a quality assurance manager for many years, but actually, in addition, several years ago, our department asked me to lead the modernization of our call center. And then after that, I was also asked to lead our alternative crisis response program as we were implementing it here. So I have some various experiences. One of my main roles is still around access to care and monitoring that and improving our access to care. So I'll talk a little bit about our system, how you can access care now, and then also in the future, kind of where we're going. Because it is a relatively small group, love feedback, ideas, thoughts, questions as we go. I'm open to it as we go. And we will just jump in. So as you all probably know, the Los Angeles County Department of Mental Health, our main focus population is the Medi-Cal population, although we also serve those without insurance, as well as we will serve individuals that have private insurance or any other type, or Medicare, any type of insurance. But our main population is the Medi-Cal population. So one thing I wanted to set the stage with, and I know Remy talked a little bit about this morning, as well as Supervisor Horvath, is that the Department of Mental Health, our focus is on specialty mental health services. So has anybody heard the term specialty mental health services before? Okay, some of you, some not. So unfortunately, under the Medi-Cal program, they have carved out what they consider specialty mental health services. So within the Medi-Cal program, the managed care plans, so think of Kaiser, LA Care, et cetera, they can provide mental health services. So if somebody has I'm going to, for lack of a better term right now, kind of a lower level mental health challenge, they can be served within the managed care plans through their system, which we consider non-specialty. However, if somebody has a more serious mental illness, or their special populations like the child welfare population or the justice involved children, or a child who's homeless, that means they qualify for specialty mental health services, which is a higher level, more intensive type of mental health services that are then the responsibility of the Department of Mental Health. So we do have kind of this bifurcated mental health system where we have the managed care plans for non-specialty services, and then the managed care, and then the Department of Mental Health for specialty mental health services. So I want to kind of put that out there to begin with. So when I'm talking about the services we provide, I'm talking about specialty mental health services for somebody who has a more serious mental illness or needs more intensive services than the managed care plans can provide. And I'll talk about that a little bit more in a minute. So we look at, there is, I know there was a session earlier today about, is there a continuum of mental health services? We like to think there is. We're continuing to try to improve upon this, but through the managed care plans, those non-specialty mental health services, they can provide evaluation and treatment. They can provide psychotherapy. They have psychiatrists that provide medication support. That can all be done through the managed care plans in that non-specialty system. Typically, what they can't do is a lot of like the field-based services, kind of those specialized services, the more frequent, the more intensive types of services using a full clinical treatment team. So that we have the non-specialty services, and then within the Department of Mental Health, we have our crisis system, and kind of what I'm going to call today is just our specialty system. Within crisis, and I'll talk more about this, is we have things like 988 and mobile crisis. We have crisis stabilization units or urgent care centers, as well as our inpatient services. And then in our specialty kind of non-crisis types of services, we have outpatient programs that do many of the same things that the non-specialty system does. So they can do assessment, therapy, rehabilitation. So rehabilitation is teaching of skills to assist in managing your mental illness. That is something that is very unique to the specialty system. That cannot be done in the non-specialty system. We also have day programs. So if somebody needs to have a program where they're at, 3-4 hours a day, receiving groups or different types of programs, it's still on an outpatient basis, but it's a day program. We have those. And then we also have residential services where it is a 24-hour type of program where somebody can receive services. So I'm going to focus today on the crisis and the specialty and talk some about how you can access them and what that would be like to get those services, and less on the non-specialty since that is through the managed care plans. So what types of services does DMH offer? As I mentioned, we do therapy, case management, rehabilitation, medication support, and we do this through both directly operated providers. Directly operated, it means that they're employees of the Department of Mental Health. And then we also contract out for many of our services to various providers throughout the county. Many of our programs also offer an outreach and engagement component. This is where individuals are going out and helping somebody to engage in our services. Maybe somebody's not as excited about mental health services or not recognizing that they have an illness that they might need services for. So a lot of our programs can do outreach and engagement. We really believe that there's no one size fits all. In mental health services, that we really have to tailor the services that we provide and what we do to meet the needs of the individual and how we can help best serve them and help them on their road to recovery. So we have been engaging in this campaign of who do I call for help? It can be confusing out there of how do I access services? Where do I go? You hear a lot of hotlines and phone numbers thrown around. And I think let's also face it is sometimes when we're in a crisis or we need help, the number we all know is 911. And I think, when somebody's in a mental health crisis, 911 might not, and law enforcement might not be the thing that you really need in that moment. And let's remember, as I tell my kids, having a mental illness or struggling emotionally is not a crime. And so we want to make sure that people are aware of these other resources that are available that might, quite frankly, be better able to meet their needs. So this is a campaign that we've started just several months ago to really try to get the word out in an easy way of where do you go to get help. And so we've differentiated between 911, 988. How many people have heard of 988? Okay, good. This is better. Like when I started Alternative Crisis Response Program, you'd ask who's heard of 988, and it was nobody. It didn't exist, right, until several years ago, but it also was, people couldn't remember the National Suicide Lifeline phone number. Like it wasn't easy. So really having that easy to remember number is so helpful. And 988 has those crisis counselors that can answer the phone right away. I think it's typically within 15 seconds, and they can provide that crisis support over the phone. We also have, go ahead. Yes, 988 and 211 are both 24/7. And all of these numbers actually are 24/7. So I think the other number that I want to highlight is our 800-854-7771 number. Now, while that number might not be the easiest to remember, And luckily for myself, when we do like Zoom calls or virtual calls, our backgrounds all have it, so I don't have to remember that number. But that number is also, that is our 24/7 helpline for the county. We've recently combined both our mental health line and our substance use line into one. So whether you're needing mental health services or substance use services, you can just call this single number and get both services. This number will help you access, and I'll talk about this more, both our mobile crisis teams, if you need somebody to come into the field because you're in crisis, or you just want a referral to access our services and understanding what services are available related to mental health. So it's an important number to know. So those are kind of the four main numbers to be aware of and kind of have. We are working, like I said, this is a new campaign. So we're working on getting these like magnets that you can put on your refrigerator or bookmarks. The bookmarks are kind of cool. Who reads books anymore? I don't know, but I do as well. My kids do. So I'm like, okay, my kids can do this, but it's like everything is online now. But I was excited about the bookmarks. Maybe we can go back and we can create a campaign of like going back to paper books. Okay, we're gonna start one. I think there's several of us here. We're gonna start the paper book club of like really making that cool again. Like okay, yeah, that's going to be, maybe that'll be our first like paper book that we really enforce as this like group. Okay. I see you taking a picture. Do you want me to stay on this slide for a minute before I'd like to take all these numbers now. Okay, yes. And you know what I can do is we can make sure that NAMI we're getting posters, we're getting everything, and we'll make sure that NAMI has them to distribute and get out. Great. Yes. Then I'll take the picture. You can still take the picture because it makes me feel like people are using the information that I'm sharing. I was at a conference last week at CrisisCon last week and was presenting on law enforcement and our mobile crisis teams and kind of best practices in that area. And at one point, everybody in the room got out their phone and took a picture. And it was like, okay, I feel like my anxiety just went down because people seem to be engaged and enjoying what I'm talking about. So I appreciate the pictures coming out. Just let me know when you're ready for me to. I can also give it to you at the end of the presentation. Yes. Okay. So I'm going to just briefly go into a little bit of who to call a little bit more. So like I mentioned, we have 988, which is 24/7. It's easy to access, right? 988, easy to remember. There's also a chat feature, and I have the link on the slide if you're interested. And again, the real benefit of 988 is that ability that you're talking to a crisis counselor as soon as they pick up the phone, right? You're not getting routed to somebody else. That crisis counselor is the person that is there to talk to you. This is best when you have somebody who is really struggling and they just want somebody to talk to you in the moment. We also, as I mentioned, we have our DMH helpline. Again, it's 24/7 and it's that phone number. Just to give you some idea around numbers, with 988 in LA County, we get about 6,000 crisis calls per month. And our helpline gets about the same number of crisis calls. And those calls are getting routed over to our mobile crisis teams, which I'll talk about in a second. And let me see if there's anything else. With 988, about 98% of those calls are able to be resolved over the phone. So no further intervention is needed. And about 40% of the crisis calls that come to the department results in a field crisis team coming out to that individual. So the teams that come out to the individual, and again, you can access these mobile crisis teams, which are mental health professionals. It does not include law enforcement. These are usually a mental health clinician paired with a peer. It is available now 24/7. That is new for us. That just occurred this past December. We were not 24/7 before, but our mobile crisis teams are now 24/7, which we're very excited about. And we're continuing to expand on the number of teams that we have so that we can get out in the field as quickly as possible. These teams will provide crisis intervention in the field. Typically, what we see is for these teams, it's not usually somebody calling for themselves. About 95% of the calls that we get, it's somebody calling on behalf of somebody else who needs help. Which makes sense, because if you know you need help yourself, talking to a crisis counselor on the phone makes sense. But if you have a loved one or somebody else that you know who's in crisis, they might not be in a state where handing them a phone to talk to somebody works. So having a crisis team come out is really beneficial. Currently, we have about 70 crisis teams that will come into the field. That does not include our teams that are working overtime to come out. 95% or so of those calls where somebody comes into the field never require law enforcement involvement of any kind. And I think that's an important piece to remember, especially when we talked about before. So when somebody's in crisis, sometimes they rely on 911 because that's the number they know. But when you call 911 most often, then that's law enforcement coming out. And from these numbers, we know that 95% of those mental health crises do not need law enforcement involvement. Okay. Yeah, go ahead.
So,
Yeah. So the question was about if you call 911 and you ask them to have a mental health team come out, is that part of our 70? No, it is not. That 70 is just our pure mental health teams. We also have many co-response teams with law enforcement. This is where we pair one of our clinicians with a law enforcement officer. And then if you're going through 911 and then requesting a co-response team, that's who's going to come out is those. And we currently have about 95 clinicians who are paired with an officer to come out. Yeah.
yeah.
And the problem was response times.
Mm-hmm.
So what are your response times now? What are the average wait for a team to come?
Great question. And this is one that I used to be severely embarrassed to answer. I'm getting a little bit more comfortable with the answer that I can give you. So, and I will say this because it's years ago. So years ago, what you're referring to, our average 7 hours. Not helpful in a crisis, right? So it's like, yeah, I'm going to call 911. Now our average is less than 2 hours. So it's really improved. Thank you. I'm feeling better about that number, but we are still working to get it. So our average is less than an hour. That is our goal. So that's what we're continuing to work on. There's certain times of the day where we know we need more teams. So we're working on that. So it is a number we're looking at every single day, kind of managing and seeing what else can we do to get that number lower. Because if we really want to have an alternative crisis response system, to be a true alternative, you need to respond as quick as law enforcement would. Now, we're never going to have sirens. We don't want to have sirens. We don't want to be like police coming out, but we need to be responsive and be able to get out there quickly. Yeah.
You want me to repeat? You want me to repeat it? Okay, thanks, Chris. What I said was you started by saying that this is mostly for Medi-Cal patients who are very needy and they're poor and they can't afford and they often can't get there. But a mental health crisis could come about for anyone if they were wealthy, if they had private insurance. I think it's important to clarify if 988 is there for everybody, no matter their background, whether they qualify for Medi-Cal or not.
Yeah, thank you. And I appreciate that bringing that up and making sure. So 988 is for everyone. It is a national number. There's all kinds of regulations and initiatives happening now to make sure that it's fully funded, to make sure that it is for everybody. It is for everyone. And also our mobile crisis teams will go out on everyone. That part of our screening criteria is not what type of insurance do they have. When we go out there, our focus is on managing the crisis, helping that individual and the family to stabilize in the community. We will hospitalize if we have to, and we feel like that's the best option for that individual. But our goal is to keep somebody safe within the community. Once we're done, we will ask some insurance questions because we want to make sure that we can continue to be funded. And if somebody has insurance, insurance requires that they pay for these things. So there's a lot of laws happening to make sure this is fully funded. So we will ask, but I'm glad you pointed that out. Yep. Yeah, thank you. Yes, yes. Yeah, thank you. Thank you for that. Yeah.
May I add a comment about
Absolutely.
law enforcement?
Yep.
So simply put, if you need somebody now, as quickly as possible, if a weapon is involved, if someone's safety is involved, don't mess around. You call 911.
Yep.
If you need somebody now, the police are slow enough as it is.
Yeah.
But you see, even a 2-hour wait time, which is much improved from the past.
Yep.
20 years ago, I remember waiting 5 hours
Yep.
for PMRT.
Yeah.
So you want to avoid calling law enforcement because you don't know who's going to show up. And by the way, the co-response teams are second responders,
Exactly.
not
They're
first
second
responders. So if you do call 911, say, I want, if it's LEPD, if you can remember this, say I want an MHIT trained officer,
Yep.
which is their crisis intervention team training. I want somebody trained in mental illness. But if you can avoid law enforcement and you can wait a couple, 3 hours for Jennifer's teams to get out there, you're much better off because you never know if things spiral out of control. Now he's committed a crime. Now you got two problems. You got a
Yep.
criminal justice problem
Right.
and a mental health problem.
Right.
So.
But in the same sense, if you can wait for the team to come out, right? Like that team is going to be able to manage that situation much differently than law enforcement. Depending on where you are with your law enforcement department, their protocols involve, if they need to take you to the hospital, they will put you in handcuffs in the back of a police car. Somebody experiencing a mental health crisis who is suicidal or really putting them in handcuffs in the back of a police car is not appropriate, right? So I think that is absolutely, if somebody has a weapon, you think they're going to use it, they're threatening to jump up, and you need to save their life in that moment. 911, right? Because you can't wait, but we are working to differentiate. Just one comment and then I go. And this is part of, the work we have been doing with law enforcement is to build up some best practices because we don't want to put it all on the caller of knowing where to call, right? So we want to make sure that if you do call 911, right, we have some diversion programs that are happening to say, like, you know what, really, we think this can be handled with 988. So we're going to route that call. We're not going to send out, right? Or if an officer gets in the field and they think, you know what, we think you might need to go to the hospital, but are you okay waiting for a mental health team so they can come out and do this in a different way, right? So we're working on those best practices. We just finalized a best practice manual with our law enforcement practices. So we're going to be working on implementing that. So it's not all on the community and the caller to know where to go. Let's also have our professionals knowing what's the best practice in those situations.
What is your advice on someone when they walk away or not there anymore? Or do you see someone on the street who has acting with symptoms and you're not available to stay with them?
Yeah. Sue, thank you for bringing up the hardest issue there is. I'm just kidding. This is one we really grapple with. Right. And so let's just take an example of somebody, maybe they're homeless, they're on the street, they're talking to themselves. And in that situation, right, it's like, well, what is law enforcement going to do? Right. Maybe not a lot. 988 probably isn't a good option either, because it's not like you can hand them a phone and say, here, talk to a crisis counselor. And if they're mobile, right, by the time our team gets there, they might be gone. Right. So here is what I would say. I would say if that person is in crisis and you think they need help, it's really not appropriate for law enforcement, call us, because we will still go out and try to locate that individual and get there fast enough to do it. I would say that is probably one of the biggest challenges that we are grappling with, of what is the best way, what's the best solution in those situations. And also, let's face it, if that person, maybe we can't hospitalize them, right? Maybe that they're not in crisis, they don't meet the criteria to hospitalize, but they really need help. That single crisis contact is not going to get that person. We'll make referrals for that person and we'll try to get them in, but that single contact isn't the best way, right? That's not necessarily going to solve that. So I'm going to talk at the end about some things that we're doing in this space to try to create some solutions. I actually had this conversation with my 7-year-old son. This is what my family talks about at the dinner table, is how do we solve these issues? And my 7-year-old son, his idea was to give our teams helicopters, so we get there fast, and then also have them trained as ninjas, just in case, like from a safety perspective. And so they didn't need to rely. And I was like, okay, that's a great idea. We need to be thinking of different out of the box solutions. So if anybody wants to come have dinner with us and participate in these conversations, we're open to any ideas and anybody to come have dinner with us. I know the ninja part was clearly, it fits for a 7-year-old boy, right? Like, I think it makes sense. You say what you know.
For people that, I'm sorry, not to put you on the spot.
That's okay. He already asked the hardest question there is. So I feel like that it all might be uphill from here.
But I happen to be from Service Area 2, adjacent to Service Area 1.
Yep.
And so we have a lot of land,
yes,
and very few resources.
Yep.
So what is the estimated time of arrival for a pet call?
Yeah. So it actually is pretty much because we do look at it by service area, and I can get you the exact numbers, but when we look at it by service area, we are really making sure that all service areas are about the same. So we're looking at resources of where do we need to put them. We're also making sure that our teams aren't limited just to one service area. Because if I have a team that's available and, where that crisis is in service area 1, I want to send that team there. So we do a lot around where do we need to dispatch those teams to make sure that there's no one service area that is waiting longer than another service area. But that is one of those key things that we are looking at and tracking over time. Okay. I'm just going to so just letting you know around some places to go. Right. So again, we're kind of in that crisis sphere area still. We have urgent cares. And so I think many people are familiar with urgent cares and the physical health medical world, right? Again, my son, who I bring up a lot in these presentations, I had to take him to an urgent care the other day because I was like, I don't know what's going on. The doctor's office isn't open. I can't get him in. So I'm going to take him to the urgent care to help. We have 9 psychiatric urgent care facilities across the county. And these facilities you can walk in to. Our crisis teams might transport somebody to one of these urgent cares and really trying to go there instead of just going quickly to an inpatient hospital, right? So utilizing an urgent care. Is everybody familiar with psychiatric urgent cares? Yeah, so many of you. So they're usually less than 24 hours, right? So somebody might stay there. The average is 17 hours, kind of giving a safe space to kind of stabilize in that crisis. You can get med support, therapy in the moment, assessment. So lots of services being provided in that urgent care setting. We have currently, we differentiate, urgent care has chairs versus beds. Beds is you're going to stay there overnight. You need a bed overnight. So across the county, we have 166 chairs currently. And we are working on expanding that to several other areas. And I have a little map here so you can see where they are. And we are monitoring the capacity of those and where do we need additional urgent cares. We have a couple in the works currently. And then we also have crisis residential treatment programs. I would say these programs I've said are kind of like the best kept secret. Not a lot of people know about crisis residential. So these, though, are typically, the ways to access that is typically through a referral from an emergency department, an urgent care facility, inpatient psychiatry, or an outpatient psychiatric provider. So you do have to get referred by one of those facilities in order to access a crisis residential treatment program. These are usually stays that are 3 months or less. And it's really meant to be, so you're not in the hospital for that amount of time. You can be in this residential setting and staying there and kind of managing that crisis. We currently have 18 crisis residential treatment programs for a total of 280 beds across the county. So we're really working on increasing the usage of those programs. Like I said, I do think it's one of those kind of best kept secrets that we are really working on expanding and making sure this is part of our mental health crisis continuum. Yeah, good. Yes, there are 2 peer respite. That is actually one of our goals for this year, is to really be looking at peer respite as an alternative to hospitalization. I was at a wonderful conference last year, actually, where nationally there's a lot more focus on the peer respite centers as being a place to refer to after a crisis. And so that is something that we are focusing on this year, of how we can incorporate them more into our crisis response system. Yeah. Okay, I recognize I'm going to be running out of time if I don't. Go ahead.
I just don't know.
Yeah. So well, Linda, do you want to?
Not really.
Okay. I'll do my best. So you want to? Great. Awesome. So better. Yeah.
I really worked there before. It's for peers that everybody works there that has mental health or lives with mental health. So it's basically, you could stay there for free. It's funded by the Department of Mental Health. And it's a house that you go to and you just stay there for free. They do support groups, they do other stuff like that. But everybody in the house actually lives with mental health. So they could help support those people when they're staying there and living there for that short amount of time. And everything is free. So yeah.
It really is an amazing program. And I think it's all peer run, kind of like you can stay there. And kind of how long you can stay there depends, but all peer run, and really just giving you sometimes you just need a break from what's going on in your life. And so giving you a safe place with peers, kind of understand what's going on. It's some peer respite centers that I've seen are very like home-like. So it's just, I think it's a different type of environment, which is very different when you think of that versus an inpatient type of setting when somebody has been experiencing a crisis. So definitely an area.
Want to ask a bit about the peer respite program, because again, we're at the opposite end of the county from Long Beach.
Mm-hmm.
So many times we have families that need respite services. Are there plans to expand respite care? Not necessarily peer, but respite is the key operative word.
Yeah.
We need relief. Many times people want to go on vacation, weddings, whatever.
Yeah. I will say, I wouldn't say there's specific plans at this point, but it is definitely the conversations that we're having of how can we utilize that. We've even talked about, our crisis teams having, and I know this isn't exactly the type of respite you're talking about, but when they go out on a crisis and maybe that family needs to be away from that individual for a night, is having like hotel vouchers they can give to the family. So just different ways that we can offer support, and really thinking of alternatives in different areas in this crisis. So a lot of ideas. And if anybody again, come to my dinner table, or just I'll give you my email contact and we can have conversations, because I think there is this alternative crisis response. I have never in the department, I've been here for almost 20 years, had something where everybody's on the same page to make this a priority. How can we really have an alternative crisis response system, which really then should not be the alternative. It should be the crisis response system. And so I think there's a lot of time and effort and focus going into this. So please give me any ideas that you have, and I will make sure that the department gets those. Okay, so I have 21 minutes to get through the rest of the system, which is ginormous. But I think it's a little bit different. So I'm going to talk about the outpatient system. So our goal, right? We don't want people just living in and out of crises all the time, right? We need treatment, right? So that you're not just relying on that crisis response system. So our outpatient system, there's two main ways to access it. One is through that 1-800 number, or you can just find the provider that's nearest to you, and I'll show different ways that you can do that. Our outpatient system, as I mentioned, assessment, therapy, rehabilitation, medication support, case management, and they will do crisis intervention if it's needed. These services can be provided in an office setting, in the home. Many times we go into somebody's home because that's where they need us, or in the community, in the field. We go on the streets if that's where it's needed. So we really, again, try to tailor it to the needs of the individual. We have various programs that are designed for specific populations and different needs. Most often, services begin in an outpatient setting. And then as that team gets to know that individual and what they need, they will refer to the appropriate program to best meet their needs. So that could be a day program, or our full service partnership teams, our FSP. Everybody heard of FSP programs? Okay, so I don't need to, just let me know if I need to. I'm going to try not to use acronyms. DMH, we love acronyms. And so I'm going to try not to use them. And we work with many different referral sources to refer to specialized programs. And I'm going to try not to get ahead of myself, because I'm working on a project right now that I'm like beyond excited about. So I'm going to talk about that in a minute. We currently have roughly 187 different outpatient sites across the county. And we have 778 contracted sites throughout the county. Now, is that surprising to anybody? Those numbers shock me sometimes. It doesn't feel that way, but we have a lot of sites across the department or across the county. And I'm not sure that everybody knows about all of them. I don't even know about all of them. So we're trying to find different ways that we can make sure that we're utilizing all of the resources that we have available to us within the county. Just because I like numbers, I do numbers a lot. We have about 11,000 mental health practitioners that work to provide services in LA County on an outpatient basis, right? So it's a lot of people and we need more. Some of the different programs that we have. So like I said, we have general outpatient, which we have 463 sites that they're just your typical outpatient clinic setting. We have 200 full service partnership sites that are providing full service partnership. We have 240 school-based sites. So they're usually located in a school and they can coordinate services with the school so that that kid can receive services while they're at school and not have to go to a clinic. 120 wraparound sites, 48 CalWorks or Grow programs. I'm just giving you these numbers so you have kind of that breadth of like what we do, and I'm not going to go through all of these. And we have over 370 prevention and early intervention programs that really are focused on evidence-based practices. That's not all of them. That is just kind of a sampling of the different types of programs that we have across those nearly 1,000 different programs that we have. So I just wanted to, and again, I think people will get slides. Will people get slides? Or maybe I can make sure you have them. They will get slides. Okay. because I did put some links how to access some of these programs or good additional information. We have, and because of a project I'm working on, we currently have over 40 different types of programs that serve different populations and have different services available. So I could not come up here and explain every single one because we would be here all day in just this session. But a couple of our programs we have, like I mentioned, our outpatient, where it's in an office setting, usually going in to get the services there. We have our full service partnership, which is very field-based. They have the ability to respond 24/7 if needed. So it's usually a more intensive program focused on those with a history of psychiatric hospitalizations, incarcerations, or homelessness. We have our home program, where these are the hardest to reach individuals who are homeless. These are home program. They have psychiatrists that will go into the field. They will work for years to engage somebody in services. These are really individuals who are not able to access food, clothing, shelter, all kinds of things because of their mental illness. These are individuals who are literally dying on the street. And so the teams are going out to them, working to get them housed, working to get them stabilized, and then we'll be transitioning them. We have our Care Court program, which I know was talked about this morning and in some of the other sessions, so I won't talk about that. And then just to mention, one of our child programs is Wraparound, which is an intensive mental health program for children with DCFS involvement. So we have all kinds of programs across the department. So just a little bit about what to expect. If you call our helpline to access these services, you're going to press 1 when you call. We've tried to reduce the number of buttons you have to press to get services. So there were some recent changes that were just implemented, and we are doing more. Typically, when you call, they will do a screening to determine if you're most appropriate for our system, that specialty system, or if the managed care plan is more appropriate. The reason that we do that is because we have limited capacity and resources. So we need to make sure that those that we are serving in our system are really those who need those intensive mental health services, right? That aren't appropriate to be seen in the managed care plan system. So we do have a screening. It is required by us, by the state. And I put an example of some of the screening questions that will be asked. Then a referral will be made to the nearest outpatient program that is accepting new clients. So that is something that agent, that call center will do, is they check to see, hey, where are they able to serve this individual? We do have some sites that are at capacity, so we don't want to make referrals to those. We also do a lot of work to make sure, I don't know if you've seen a lot of the news articles lately about these ghost networks. So a ghost network is where a health plan will say, hey, here's all of our resources. Here's all of our clinics. But when you call them, they don't exist anymore. They've gone out of practice, or they've closed, or they're not accepting. So it's called a ghost network. So it looks really good on paper. It's not cool. It is not cool at all. It's really, I mean, can you imagine? You're like trying to get help and then you call and there's nobody. So we are making a lot of efforts to make sure that we do not have a ghost network. This is something we are working on every day, working to continue to improve upon. So they will make sure they're referring you to a clinic that is accepting new clients. And then that clinic will call you to schedule an appointment, and that's usually within 1 to 3 days. The other option is you could call or walk into the nearest clinic. In that case, they may screen you. They don't have to, but they might screen you for specialty mental health services, or your loved one, obviously. And then also they will either provide same-day services or schedule you for an appointment. This is our online provider directory. It's not perfect. I will be the first to say that it bugs me. But it's made improvements and we're continuing to improve upon it so that it's easy to use. And kind of what we're doing is you can see is we have some questions that it asks you, right? Like, what's your zip code? Are you looking for outpatient services or are you looking for an urgent care center or a hospital? What's your age? What's the language? Do you have a preferred language that you need? And then we have it defaulted to say, hey, only show me those sites that are accepting new clients. But if you're like, oh, I just want to see everybody, you could also do that. So this will help us so that you can find a clinic or a program when you need it. It's available on our website. And like I said, we are working to continuously try to improve upon our provider directory. Okay, so I have 10 minutes. And again, if you have questions, go ahead. But I want to tell you about our future, because this is what I am most excited about. So right now, all of those programs that I mentioned, if you're looking for help for yourself or your loved one, we kind of expect you to know which program is going to be best for you, right? Or we're just going to send you to a clinic, which, you know what, my loved one is not going to walk into a clinic. So how is that helpful? And so we recognize that. And so what we are doing is we are building what we're calling a universal entry system. And with this, it can be a single access point for all referrals coming into the Department of Mental Health. It doesn't remove or replace any of our existing access points, but it's a new one that we think is going to be a lot easier for the general public to access our system. Our aim is to assign potential clients to the right program upon initial entry into our system and screen clients in an equitable manner. Because we also know some of the research says that if you leave it up to an individual to make a determination of the needs of that individual, they're biased. And you see different individuals going to different programs, maybe based on their race, their age, their ethnicity, and various factors, right? And so this is going to hopefully make it a little bit more equitable. What it does is it has a standardized decision-making tool built into it. So we are doing the work to analyze all of those programs, those 40 plus programs that we have, looking at the differences between those programs, what are the key criteria for each one? And then we're offering up questions that as you're making the referral, you're putting in information, and we try to keep it as simple as possible. It's not a million pages. And by answering those questions, it's helping us determine what's the best program to best meet the needs of that individual from the beginning. And so this is something that we're currently working on. These are just some of the values that we're keeping in mind as we're developing this. And again, our goal is to make it as easy as possible to access our system and get somebody to the right program from the beginning, instead of having to wait until they've been in our system for a while. This is really hard to understand, but I'll kind of point this out. Can you hear me still if I go like this? Okay. So the idea is you can go online to a public portal, fill out. Should I do that? Would it be better? Oh. Yeah, I know. It's always the worst. Okay, is this on? Okay. So the idea is you can go through this public portal that's online, fill out a quick questionnaire with some information that you can also sign forms, right? Like if you need to do a consent form, get HIPAA notice, privacy practices, any kinds of things, getting that done up front. Because again, we want to reduce barriers to accessing care. Then that'll go through our, decision-making tool. I'm scared of AI. So I don't want to call it an algorithm or AI, because that's not what it is. It is, we made decisions. So it'll go through that, and then it's going to determine which program is most appropriate. And one thing that I'm excited about is if it's going into some of our programs like outpatient, a typical clinic, you will also be able to schedule your appointment right there and then. You get your appointment right in that moment at any of our sites, both directly operated and contractors. So that is kind of like the vision of where it'll go. And then we'd have like some type of support team, right? If you need more help in that process. One thing I will mention, we are currently doing this with now I have two mics. We are currently doing this. We first rolled this out with our street outreach workers. So those individuals who are out in the field working with homeless individuals, they needed an easy way to refer to the Department of Mental Health. They do not have time to go back, figure out which form to fill out, determine which program to send that referral to. So they are now using this to refer clients into our system. We also have trained the Metro workers on how to use this tool. So they are pulling up their phone, talking to an individual and making a referral over to our system. We started that in May of this year. And so this has been it's been going well. So we're in the process. We're going to be rolling this out over the next year or so to different referral sources. Eventually it'll be online and anybody can utilize it, but we're going a little slow in it. We're not just opening it up because we have to make sure all of those decisions that we're making are right. So we're gathering outcomes. We're looking at, is this a faster way to access services? Is this working? Is somebody getting into the right program? So we're doing all of those things as we're building it out. So we'll be rolling it out to more referral sources, more programs over the next year. I know, I'm so excited about it. Oh, I turned it off when I had double mics.
Barriers. I'm an end user referral source.
Yep.
And I work a lot with families. And most recently, this week, actually, we spent at my agency, my little agency, we spent an enormous amount of time over the issue of an ROI.
Yep.
So I went and got on a Sunday afternoon a new ROI signed by the client.
Yep.
Drove it in on Monday, only to discover that DMH doesn't take outside or our releases of
That is
information.
not true. Please talk to me. That is not true. We will accept those as long as they have all of the required.
Yes,
recognize
I
there's
need to talk.
10,000 people and they don't always get all the directives we put out to them.
So
but yeah.
my question was,
Yep.
can we download
Yep.
your special form?
Absolutely.
And I was told, no, it's not available.
What?
That was what I was told.
Okay, afterwards, come tell me who you talk to so I can go
I don't want to put them
educate.
in bad light. I just want to make it
I
work.
just want to educate them because I think that is sometimes what we see is, I mean, as you can see, our system is giant, right? We have 11,000 people. That's hard I don't know how they do it at the national level, but I was like, how do I make sure everybody has the same information? This is part of that, right? Is building a system where it's like, we're doing all of that, like almost centrally in a way while still being individualized because we want to make sure that you aren't getting that misinformation. You're not getting turned away for something that, I mean, my job in quality assurance, I'd be like, that is not true. Though you can't turn somebody away
had
for
a
that.
client go homeless because of
Yes.
the paperwork.
Yes. So that is what, we're really striving to do. You'd be able to get those forms here. You'd be able to make the referral, reducing those barriers. I mean, how many times does somebody not get the care they need right away because you don't have the right consent form or you don't, so
Hallelujah.
that is what we are striving to do. We're not there yet. We're not perfect, but we're continuing to make those tweaks as much as we can every day.
Thank you.
Yeah. All right. We have 2 minutes.
Back then. And so I know what you guys do are amazing. You do amazing things. One of the things I've been bugging our district chief about is getting the glossary updated because you people
Yeah.
live on alphabet soup.
I know we do.
And
We do. I can't even understand myself sometime when I talk.
but that
Yeah.
glossary is way out of date.
Yes.
So that would be good. And the other thing I want to mention for people new to NAMI, we have something on the website called Navigating a Mental Health Crisis. And at the back of that book, there's quite a few pages to keep your health history stuff. And, as you turn it into other things, you may need to tighten it up, one pager. But that's a good resource. And sometimes I think the professionals in our lives don't know what we have.
Yes.
So I always like to share that. But thanks for all you do. I'm in service area 7, but
I would love to talk. So we are working related to crisis. We are working on a marketing campaign. One, we want to get out information about what is available, how to access them, but also provide information about what to do in a crisis, how to work with somebody, talk to somebody. So if anybody is interested, you have experience in a crisis situation or a loved one, I see that to wrap it up. Please come talk to me because we're looking for people to help us in this marketing campaign that we're going to do. Sorry.
Oh, we have one more question.
You asked for ideas. Quick idea. I'll be real fast. So law enforcement, as you know, in 2019, no longer puts hands on people.
Yep.
So they go to do
Depending on which.
assuming no crime has been committed.
Yep.
Right. They show up. Guy says, I really think you need to go to the hospital. Guy says, forget it.
Yep.
And he walks away, as Paul was saying before.
Yep.
When we have the resources and enough maybe peer teams to go out, what is the actual, could you assign a peer team? So when law enforcement says this episode is failing, this guy's going to walk away. So you had somebody who was untreated, law enforcement comes, he walks away, still untreated.
Yep.
Then you have a peer team come up and they follow him down the street and buy him a cup of coffee and talk to him. And then maybe, is that something that could happen in the future?
Yes. And we can talk about some of the things that we have happening in that area. Yep. I'm going to let you go even though we're over. Go ahead. I 100% agree. Yep. Yep.
And the website's a mess. That's, you can't find anything on it.
100% agree with you. And I actually talked to my staff about that exact thing yesterday where I said, if I was somebody looking for help, like this is not, so I am with you. And I asked my staff yesterday to work, we need to come up with a plan on that. Yes. I'm there. And if you have ideas, let me know because I'm going to be working on that because it's not helpful. All right. Well, thank you all for coming. I will stick around if anybody has any additional questions. Really appreciate all that everybody does. Thank you. Be safe, be healthy out there and take care. Thanks, everyone.